Our next speaker is a good friend of mine. His name is Dr. Ricardo Kern. He's from Brazil, and he is firmly entrenched within the high aesthetic requirements of Brazilian dentistry. Ricardo focuses his work on the demanding disciplines of soft tissue design and soft tissue reconstruction. He has vast experience in immediate implant placement with temporization from single tooth to full arch rehabilitation. He's been invited to lecture and do trainings about soft tissue design, preservations, and reconstructions on several post-graduating courses, as well as in many congresses and seminars from Latin America and overseas and all over the world. Ladies and gentlemen, I'd like to present my friend, Dr. Ricardo Kern.
Thank you so much, Greg. Good. 1, 2. Good morning, everybody. For me, it's a huge pleasure to have your time this morning. We talk about that time is money, but actually time is much more than that, because money you can work and make it again. Time, once the time is gone, we never have the time back. And I'm really glad for you guys to be here, giving this time to me this morning. And I'm fully going to compensate this time that you are giving to me with very important information, okay? So thank you for being here today. Thank you for supporting the sponsors. And my job here is try to bring some important techniques, so tricks and tips for you to go home and try to apply that for your patients. We're going to talk about immediate implantation, but we're going to bring here some small points, some small insights for you to perform more precise, faster, better, for especially the case that has high demanding expectation for our patients. And you're going to focus not just about the points that you're going to see or the right pink frame of an implant. You know that for you to have a perfect implant, a perfect crown over implant that is framed like the natural teeth that won't belong there, I need to have the gingiva over there. I need to have the good emergence profile, good papilla. Otherwise, you're not going to have a crown over implant that seems like the natural crown that was there. But a single crown between two natural teeth, a single implant between two natural teeth sometimes is not so challenging. We already have working this information for a few years, how to handle this case. If I have very good bone picks, sometimes the pulcal deficiency is not the challenge anymore. But we're going to bring today some information how to deal with case when I have two implants side by side with compromised bone picks, okay? In this case, I started to treat in 2014. It's a static rehabilitation. At first, I was preparing this patient just for the new veneers here. We have done crown lengthening one side, CT graft the other side, try to balance the pink frame. Otherwise, you're not going to have the aesthetic for the white restorative part of the patient done correctly. So we graft one side, have done crown length on the other side, try to fix the zenith position, framing better this crown. And after almost half a year, I'm going to have the chance to run for the final crown. I have one of the premolars here that is very interesting. I have done this implant immediate place in 2005. And 9 years later, if this has a very good phenotype, you are still have a little more gingiva that we need. Is the powerful of the good phenotype that you have to work in hands. And what I need to have for this case, if I was doing crown lengthening in the other crowns, I need to push the gingiva. I need to do the conditioning state of the gingiva, and I'm going to talk about this zone in a few slides, how to do this step by step very precisely. So after the whole prosthetical part done, I deliver the final crowns for my patient. The papillas improve a little bit, but I still need to have something else. If you do the restoration of the contact points, if you bring the contact points better aligned with the soft tissue margin, if you have better, how can I say, healthy tissue around there, healthy or better line angles as well, we need to wait the time to give the impact for the papillas to be back. So 8 months later, after the installation of the final crowns, we have here a beautiful tissue scalloped gingiva around our crowns. But we're here to talk about implants, right? In this case, so far it's not a case for an implant. until 5 years late, 2009, 2020, the patient was riding a bike in one of the parks of my city. I live in the south part of the Brazil. The city is Curitiba, it's a very nice green city. And I don't think the patient is too good riding a bike. She fell from the bike, bit the two central incisors, breaking the two central incisors exactly in the center. There is no hope for this kind of situation. No, it's going to be the extraction. There's no episiotomy, no crown lengthening, no extrusion. So I need to really bring these two incisors out and I need to place two implants. What is the challenge in here? We work so hard to develop that papilla, work so hard to have a aesthetic case done for this patient. And now I need to place an implant here with a very narrow bone peak. And also, it's not the best bone peak, as you have seen the lecture this morning. The distance from the contact point from the bone peak when it's 7 millimeters, the predictability for me to have a papilla there is below 30%. Just below 30% of the case are going to have the papilla. And if I place two implants here, usually what happens with this narrow bone peak? We lose a little bit of the bone, can be 1 or 2 millimeters, and that is going to be a long space for the papilla to fill. How to deal with this case and deliver the papilla in this interproximal area. So I'm going to place the two implants first. The step is a traumatic extraction. Nowadays, you have many different gadgets that you can do the atraumatic extraction, benign extraction. There's so many in the market nowadays. But when I start to place implant in 2004, 2005, immediate implant placement, we need to extract this root here without these instruments. So basically we have drills, periotome, forceps to make the job. And I still do the same step by step because this process helped me in a few cases to do socket shield as well, okay? So how we do that? I cut the tooth in half. I separated the buccal fragment to the palatal fragment. Open a completely space between the two fragments. This open space make it easy for me to detach the fragments from the bone socket wall with minimal trauma over the soft tissue margin. What is the problem? Because when I cut this root, not all the time I was in the center of the root. Half of my case I was cutting much palatal, half my case I was cutting the buccal plate. And what is going on that? I'm a perio. And for many years, I did also general practice. When I was practicing general practice, preparing, doing endo, core preparation, all the time I was in the center. I have many cases done. I have one single perforation. But when I was cutting the root in half through extraction, half of the case I was not doing the right job. So what is the problem? If there is one good definition about mindset in dentistry, is about this one. When you go to extract a tooth, you need to think that the extraction needs to be faster. You're going to have 1 or 2 minutes to extract the tooth. When you do an endo, you do it slowly, step by step. You are more careful. The mindset of an endo, classical music, light, magnification, maybe a microscope, go on 1 by 1 millimeter. How is the mindset of a surgeon? Wow, angry man to extract the root in 30 seconds. So we start as an endo, finish as a surgeon. First, drill in the center of the root. If I'm going to drill in the center of the root, I'm going to be sure that in the center of the canal, I'm going to be sure that the splitting of this fragment is going to give me exactly balanced fragment, buccal and palatal. So first of all, I go slowly in the center until I transfer the apical part of the root. There is any problem if I bring the drill here 1 or 2 millimeters? Not at all. This is not a, how can I say, area that I need to preserve 100%. In a few seconds, I'm going to bring a big drill for the implant anyway. When you go straight down, then you go sideways, you're not going to see your drill in the tipping part of your root. But also this part here of the socket is not important. You cut sideways, mesial distal. When you get close to the bone peaks, that area you can see what you're doing. So you're going to preserve the buccal plate and you're going to preserve the bone peaks that are the noble area for an immediate case. Now I'm separating the roots here, and I need to really separate the roots completely without any connections of the dentin between one to another. So this make the extraction easy. If make the extraction easy, I can really preserve the socket inside. So this is the first step, not to bring any trauma to the socket and preserve the tissue since the beginning. And now, how to preserve this tissue in place? Soft tissue grafting, bone grafting inside the jumping gap, or a good provisional. From these three, if I want to opt just for one, the provisional is going to play maybe the most important job to preserve the scallop tissue around a fresh socket that you just extracted. And how is the design? We already have many information this morning about that, but for me, the first millimeter of the provisional here, when engaged inside the socket, can give the support for the papilla and the margin to be there. Without this mechanical support, the tissue changes. Not much, can change just a little bit, but maybe 2 millimeters is much more that it can affect the case that you want to maintain for the patient, okay? I do not need my provisional engaged side in the socket more this 1 millimeter. I do not need my provision engaging 2, 3, 4 millimeters in the side walls of the socket. Why is that? Because if you maintain the subgingival margin of your provision touching the borders all the time, the space is just filled with the acrylic. And I need to give space for the tissue to have the blood clot, the bacteria here, or the biomaterial to transform in gingiva, connective tissue, or bone area. So the first millimeter of the provisional engage sideways, then we design as concave as possible without being retentive, okay? And you're going to discuss about that. That is going to help me to improve the thickness of the gingiva, in many cases without the need of any connective tissue graft, okay? What else? Okay, besides or below this margin that the literature call the sealing zone, this first millimeter here, the critical zone, we call that sealing zone. That is the role of my provisional supporting the borders of the socket. The literature convention call that subcritical area. Everything from this first millimeters that my provisional, my crown that engage the gingiva is the subcritical area. But there is much more information in this area than just call that subcritical. Why is that? Everything that you are placing inside the socket matters about the relation that you're going to create between the tissues and the implanted, the abutment and the crown, okay? For example, if me and you, if you want to have bone around our implant, if I want to have bone around my implant here, or maybe in the top of the platform, what I need to do? I need to protect this bone. From the bacteria, from the mouth, from this bacteria not to get to the bone, I need to build up a defense system, a barrier for this bacteria not to go to the sulcus to get to this bone, right? In the tooth, what you have? The biological widths. In the implant is something very similar. I have a little bit of sulcus, I have the long junctional epithelium. Below the junctional epithelium, I have the connective tissue attachment. These structures are important for the bacteria not to get to the bone. But let's see something. What's matter here that is very important for what I want to discuss with you guys today. The connective tissue attachment, that is most important piece of the defense from the bone, just can happen in a biology-friendly surface. The connective tissue attachment just can attach it to a biocompatible surface, and in this case represented by the abutment, the titanium abutment. When the tissue is healing, the blood clot is healing, the new tissue is going to face the titanium. Okay, this is a biocompatible surface. I can start to attach and build up the connective tissue attachment. Connective tissue attachment cannot be against a non-biocompatible surface like the acrylic. Acrylic is a foreign body. Acrylic is a strange material. When the blood clot is being organized inside the socket and the new cells is healing against the acrylic, This is a strange material. I cannot have the connective tissue in contact with that. I need to protect the connective tissue. And the protection of the connective tissue is the epithelial layer. So I'm going to have the long junctional epithelium over there, create one more layer between the connective tissue and the acrylic. This layer needs more space, and you're going to see how that impacts the interproximal bone peak formation later. What happened during the time or the healing, this long junctional epithelium that established against the acrylic tends to create a keratinized line, a keratinization. What is a keratinization with epithelium around the socket? Is a big sulcus. So you can manipulate, we can interfere, you can influence how much connective tissue attachment you are going to form around the implant, or how much sulcus you're going to work or form around the implant according to the materials and the extension of the materials that you are working inside the socket, okay? First of all, I need to bring you to convince you guys about the importance of the provisional. Why is that? I know that you guys like surgery, you like blood, you like blades, you hate provisional. Most of you, right? You are a surgeon, usually you don't like much the provisional. And I need to give the importance of the provisional for you to improve the results, your skills, how much effort you are putting in your surgery. And sometimes the provisional is going to give you this small up in the results. So this case here is a case from a cousin of mine. I don't know what happened here in your country, but in Brazil, every time that you're going to help a relative, something goes wrong, right? It's the same here. So no hope for me to place an implant. I'm going to extract this premolar. And I think this case was in 2014. I extracted the premolar. I did a socket preservation using PRF plug. And PRF plug can be good, can be not. Why is that? Because the plug is going to stay here just for 7 days. After 7 days, if you work with PRF, you know that plug is not there. If the plug is not there, where is the mechanical support? Mechanical support is not there. So if I have a very scalloped papilla, usually this papilla collapses, the tissue collapses. So I prefer to give the support nowadays with a provisional. But this does not matter. He's my cousin. In the first day, he mouth rinsing the plug, the biomaterial, everything out. We lose the support of the socket, and the socket 7 days later, all had collapsed with some contaminations of the biomaterial inside. What I'm going to do now? In the day of the extraction, I have taken the tooth out and I make an impression, removing the two composites on the interproximal side. 7 days later, in the day that I was helping in removing the sutures, I have this provision in hands. So we're going to just clean the biomaterial that was mobile inside the socket. I do not need to remove it all. The biomaterial that is still stable, organized, I'm going to let it that. And I'm going to promote a blood clot inside the socket, okay? Who is going to stabilize and is going to take care that the blood clot is going to stay calm down inside this socket? Sutures. No, the provisional. You're going to see that we have realigned the provisional here. We have some excess of the composite inside the socket, some excess of the composite outside the socket, and I trim this provisional in order to reestablish this line here. Which line is that? Is my sealing area of my provisional. When I engage this provisional, this area is going to seal the socket entrance, stabilizing the blood clot, but also giving support for the soft tissue in the surroundings. So we do not graft anymore. We do not do any surgical maneuver, just the blood clot and the provisional. This is not the best view, talking about the aesthetic result, especially in a relative, right? This relative going in your gathering from the family, all the time my cousin was showing the tooth for the other relatives. Look, Ricardo, he's a good speaker. I don't think he's a good clinician. Look at the tooth. Okay, what I'm going to expect after 2 months? That the tissue is going to collapse a little more. 2 months later, look at the follow-up. Tissue is back, alone, nothing was done. So the importance of a provisional, a pontic, or a provisional over implant for the tissue, toward the papillas, for me is one of the most important pieces of the game talking about immediate implant placement. And how I can design that. When I do a provisional, I need to take care of this area. Sealing is on. When you guys extracting a tooth, you pull out a tooth, I need to bring the provisional supporting all the borders. The problem is, every different tooth that you take out, the design is unique. I need to customize a provisional just for that area. If you let that to do that in the time of the surgery, it's going to take you maybe 15 to 20 minutes to design a good sealing zone. And you like surgery, you don't like much provisional, this is a little bit boring. So if you do not like that, what you're going to do? Give to someone else, right? Do not need to give someone else after the surgery. You can give that before the surgery. What I mean with that, when you make an impression, can be analogical digital workflow, your technician can realize that needs to protect the sulcus. Usually when they design the provisional, they are not so careful about the margin. They remove the plaster material, sometimes with over contour, sometimes with under contour. Who is going to be the one that needs to adapt there in the surgery? Me and you. But if your technician really respect the sulcus and give you a provisional that engage inside the socket for 1 millimeter, the sealing zone is ready for all the socket, for all the different tips. And how is the design of the provision that is going to start to discuss now, but you already have seen in this slide below this margin? As concave as possible without be retentive for all the different teeth that you are pulling out. A concave realign is faster, easier for us to do. We do not need to think much. You have the difficult part done before, the easy part you can do in the surgery. So the idea is to do as concave as possible because the margin of the gingiva was already supported by this first millimeter that we call sealing zone or critical line. Why as concave as possible? Looking at the screen and you're going to realize why is the reason for that. Because if the gingiva is going to stay in place by the first millimeter, there is no reason for me to bring this provision with a lot of acrylic filling inside the socket. If you give space for the blood clot, you can generate the space for much more gingiva thickness compared if you have a convex emergence profile. A convex emergence profile is not going to give you the space. After the healing, the margin of the soft tissue is going to be very thin. Thin soft tissue is not stable. Thin soft tissue does not protect as much the bone. Thin soft tissue with time is going to collapse. So a lot of speakers says, I need to place connective tissue graft 100% of the cases that we place implant in the static zone. Depends. If I already have an initial good phenotype for the patient, and if I do a good design of my provisional, I'm going to create much more thickness without any connective tissue graft. Help yourself. Do a good design of your provisional. Give the space for you to have this space. There is plenty of literature around that. Thicker phenotype, way more stable. And of course, even when I use connective tissue graft, we adopt a concave emergence profile. Nice. So we have a traumatic extraction so far. I have my provisional done. Is it time for me to place my implant, right? First thing, how deep you place your implant is a good question, right? Everybody has a formula, 2, 3, 4, 5 millimeters, according to the brand that I have, according to how much the manufacturer told me to place that implant to be crystal in the bone level. And everybody repeated the same formula for all the cases. But my patient is different than yours. Sometimes one tooth is different than the other one. If I want to nail my case, if I want to deliver my case the best I can, I need to understand what matters when I place an implant. So let's just simulate 3 different situations here. Imagine that I'm using the same abutment neck for the 3 cases. Position my provisional with the sealing zone exactly like the same. And here I place my implant more close to the socket. What happened? I let less space for the transition or the emergence profile of my provisional. With less space between the abutment and the margin, what happened with the emergence profile? Is almost vertical, almost retentive. For this simulation here, I think it still works, but a little bit more shallow than that is going to be retentive for the patient. The patient is going to complain about the floss engaged, maybe not clean so much. So I never try or I never plan to place an implant shorter than this. So Ricardo, why not to place an implant really deeper? Place the implant deeper, place the abutment deeper, so you have a lot of room to realign your provisional. With a lot of room to realign the provision, how the emergence profile. Vertical, easy for the patient to use the floss. The floss go easily inside the crown, easily out. Patient does not complain about that. What's the problem? If I'm going to realign a provisional of acrylic very deep in the socket, how is the relation of the tissue that is created against the acrylic? I can have connective tissue attachment. No, you're going to have long junctional epithelium, and with time, you create a keratin between one and another. You create a deep sulcus. A deep sulcus, if it's too deep, sometimes the patient cannot clean so much. So I'm going to avoid, and maybe this work. Yes, this can work, but deeper than that is better not to place an implant. So what we're going to do? Let's plan our cases to be between the borderlines, to be in the middle. Not so deep, not so short, to have good room for the soft tissue. And let's see how we're going to do that from one case to another. The question here is not so complicated, but you're going to see. People usually think about how deep I place my implant. I implant deeper, the emergence profile is more vertical. I implant more shorter, the emergence profile is more horizontal, retentive. But people just think about this dimension. How is a socket? Socket is a three-dimensional thing, okay? And one question, when you are drilling your implant, where do you drill your implant? Where you perforate your implant? Where the bone is? In a flat socket, where is the bone? The bone is in the palatal side of the socket. For 80% of the tooth that you pull out, the bone is going to be palatal. It means that you are drilling here. And from one tooth to another, from one patient to another, this palatal bone is going to be with a different distance between to the cervical margin. For example, in this patient here, I was extracting the central incisor, but I simulated the extraction of the lateral incisor and I simulated the extraction of the canine. And it's the same patient, but how is the socket of a lateral incisor? Very narrow. In the canine is very large. For the same, okay? Eventually. Good enough. For the lateral incisor, as the bone is very close to each other and the implant is with the same simulation of penetration of the implant here. So you're going to see for the same simulation of implant depth for the lateral incisor and for same simulation from the canine is giving completely different space for the emergence profile. In the canine, if you're going to see here, the implant is way palatal. If the implant is way palatal, in this case, what is going to be better for me to have done with the implant? Maybe drill 1 millimeter deeper, right? So we're going to have more space and better emergence profile. And in the lateral incisor, if you had drill 1 millimeter less in the lateral incisor, is still the emergence profile is going to be with the right inclination. How am I going to know that in the daily basis in my cases without much, how can I say, concern? How I can predict to do that? You can do all digital workflow. Of course, you can plan that in 3D in the computer, but not all the time I can do that. Few cases, patient came with a broken teeth, I'm going to pull out and place the implant. I have no time for making guided. So very easily if the inclination of the emergence profile is dependent how deep I place the implant in the platform, but also how close this implant is from the margin. I have a vertical and a horizontal compound. How am I going to do that to stay with an emergence profile that we consider not so deep, not so shallow? The emergence profile that is simulated, that's in the middle here, simulate a 45 degrees inclination for the abutment platform, okay? What is a 45 degrees angle in a triangle? 45 degrees in an equilateral triangle is this internal angle here, okay? I think a few of you guys are figuring out in the solution to achieve an emergence profile with this inclination, 45 degrees. It means that the distance of the abutment to the margin vertical is the same distance from the abutment to the margin horizontal. So when you guys pull it out the tooth and you start to drill your implant, in the 2.0 drill, you're already going to see where is going to be the abutment platform. You have your abutment selected and you're going to see your abutment and you can measure the distance of the abutment from the margin. Imagine 2 millimeters, and I'm going to drill 2 millimeters more to the implant length, to the abutment neck, and all the time I'm going to place this platform with 45 degrees for the emergence profile of your provisional. So first, when you are drilling, in the 2.0 drill, that you still have time to drill more or less, I can measure this distance, and this distance I'm going to add in the drilling protocol. So implant length, abutment neck, and horizontal problem for me to have the 45 degrees. 45 degrees is the angle. But as we do a concave emergence profile, your implant, or sorry, your crown, your provisional, almost emerge vertical to give the space for the tissue sideways, to give space for the bone and the soft tissue. Okay, so this is the inclination of the emergence profile to stay in the same. Different abutments is going to require different protocols, but the reasoning line is going to be basically the same, right? Tapering implant for us to achieve primary stability. If I have only one tip for you to give to you guys about primary stability, you can read the bone in the CBCT, you can read the bone on the x-rays, you can have your implant system, but two things. Know the system that you work, okay? And second thing, do one exercise. Because you are nowadays work so much in the automatic pilot. You drill, okay, let's place the implant. Oh, not so good at primary stability. Zita just brought a lot of reference about that. Do one exercise. In the 2.0 drill, guess the bone that you have and make the strategy to get 45 newtons of primary stability, minimum. And change this protocol if you need it. If you are reading the bone, oh, this is a little bit soft bone. In the 2.0 drill, you still have the time to modify the bone. But if you drill too much, it's going to be too late. Okay, so in the 2.0 drill, and make again, drill the 2.0 drill, try to get 45, 50 newtons. And all the time, if I need to condensate the bone with osteocondensate, whatever I have, with summers, with denser bones, whatever, to get for the 50 newtons, modify. If you think the bone is good enough, just drill the regular protocol. After 10, 12 cases, doing this, paying attention what you're doing, you're going to see how much you're going to improve in reading the bone. Sometimes you lose the feeling, and you're going to create the feeling paying attention what you're doing, okay? So let's go there, implant in place, 2 implants is going to be enough stable for me to place my abutment. And which abutment am I going to choose now? Okay, I'm going to modify this case in a few things because what? I want to take care of the interproximal bone. And based on the information that I discussed with you guys already before about the biocompatibility of the abutment, remember? The connective tissue just attachment in a surface that is biocompatible. So we're going to try to use abutment that is biocompatible from the implant platform until the sulcus, until the margin, to give way more room for the connective tissue to attach and way less room for the sulcus to form after the healing area. In this case, we use PICC abutment that I can customize chair side. Is one way for you to do that chair side using PICC abutment. That is a very easy material for me to shape, concave. And you see here, it's going to be from the implant platform until the sulcus, everything is going to be biocompatible. Nice. These are the materials that are biocompatible: PICC, titanium, and zirconia. Of course, titanium and zirconia is very difficult for us to customize chair side. One solution is for you to do an implant guided and do the abutment before the surgery, but not all the case you have the precision of the implant place to have this abutment done that. And the difference is, if I have a customized abutment and not a stock abutment with a lot of acrylic, I'm going to have much more room that is biocompatible and much more area for the connective tissue to attach it, okay? This was the cases that was discussed, or this influenced by the first lecture in the morning by Andre and his brother. And I'm going to bring to you guys some insights about how that is going to influence the outcome for our cases. 2 abutments is going to be in place, screw retain. Be careful that the PICC does not bond with acrylic, PICC does not bond with composite. I need to create some asperization or retention in the surface of the PICC in order for the provisional to really engage over there. And after the 2 abutments in place, I have my 2 provisional to realign over. It's going to be a screw retain solution. I use the old crowns for the patient, the crowns that the patient arrive in my office in hands after the accident. I open a small canal entrance in the palatal area. We have the Teflon tape here to avoid for the composite not to get in the chimney. And after finding the position of my crowns, I'm going to do the photopolymerization. If I had any gap between the crown and the abutment, I can fill the gap outside the mouth after do the photopolymerization. Okay, here is the gap. I can use flowable composite. I'm going to fill the gap. I'm going to trim out the excess. I'm going to clean everything. It's important for you to keep it clean. Take the rest of the polished material, the dust, everything. Is a biocompatible material, but this biocompatible material need to be clean, right? And concave, 45 degrees, giving more space as possible for the tissue, as we have discussed in the previous case, and you already know the reasons for this slide, okay? So one thing, this is the graft that we have done in 2014, was still growing a little bit, is a tuberosity graft. And in the other side, I have a very good phenotype of the gingiva. If it was based in this phenotype, I have not used CT graft in any of this socket. I just place a connective tissue graft in this socket here because I need to compensate the volume, the static volume between one side to the other side. So we're going to use a small connective tissue graft. Inside the socket, we're going to fill that with xenograft to compensate the rounding of the bone contour. And after that, the connective tissue graft in the other side. So in this socket, just biomaterial. In the other socket, biomaterial and a small CT graft to compensate the volume between one and another. And there is something else. Look at the biomaterial here. The biomaterial was filled a little bit up to the bone level. We brought the xenograft 1 or 2 millimeters coronal to the bone contour, and you're going to see that in the x-rays in this sequence. And after that, I'm going to have my provisional to seal the socket entrance here. And this is what we are discussing about. Look in the bone peaks, a long distance to the contact points. And here I have the biomaterial filling inside the socket with 1 or 2 millimeters more coronal than the bone peak level. That is just going to work if I have the space and if I have the mechanical stability promoted by the sealing zone of my provisional. Give the stability for the biomaterial, give the stability by the blood clot inside, okay? Nice. So let's go and see the healing. Immediate post-op, lateral view, central view. 7 days after, 3 months later, we lose a little bit the papilla. I was afraid about this kind of outcome, but wait a little bit about the result, right? Impression, copy and paste my abutment here to make the impression. This, a few years ago, we asked for the technician a try-in coping. This is going to be a customized zirconia coping, but I asked before the zirconia a try-in of acrylic, because in the beginning I have a lot to discuss with my technician, how is going to be the right design, and the plastic material allowed me to change, to adapt, to trim way easier than a zirconia coping. What is the idea? That this zirconia coping is going to be below the margin for 1 millimeter and is going to present the right contour. If I have done wrong this step, you're not going to achieve the proper aesthetic of the crown. And how is that? I'm going to have the abutment as concave as possible without the retentive, finish between 0.5 to maximum 1 millimeter below the margin, and the margin cannot compress the gingiva sideways. Need to have some thickness of the gingiva. So you're going to scan this abutment, then I'm going to receive the final abutment. I'm going to try in the abutment once more. And if everything is fine, I can cement the case and I can deliver the case for my patient. It's not the best case scenario when you talk here in front of you, talking about this challenges that case in the papillas, but you have done everything right. And if you have done everything right, I need to see what is going on inside this structure. Inside this structure means pay attention on the x-rays, okay? So the pre-op, I see the bone peaks over the gap filling that you have already noticed in the sequence. 4 months of post-op, not much to see, it's still too soon. But with 8 months and 1 year follow-up, what is going on here? I have a good relation with the bone to the structures that I brought together. Have a good relation to the bone with the abutment and with the crown. Why is that? Why the bone get wider and why you get the bone more vertical? One thing, first, respect for all the points that you talk about the biology here. And if this area was biocompatible since the beginning between the bone and the abutment, I just have the connective tissue. If I had here a non-biocompatible surface in this crown, because this is zirconia, in the beginning this was PEEK, everything was biocompatible. If this line was not biocompatible, the connective tissue could be in contact with this line, yes or not? No. What is going to be interposed between the connective tissue and this line? Epithelium. The thickness of the epithelium layer when creates keratin is minimum 1.2, 1.4 millimeters. 1.4 millimeters, what happened with the bone sideways? The bone needs to be far away from the abutment. If I lose 1.3 millimeters of the bone here, and if I lose 1 millimeter, 0.3 of the bone here, what happened with the bone peak? The bone peak get narrow. So the idea to give the space for the tissue and work biologically is because I want to build up the space for the bone to be shaped between one implant and another, okay? That is the summarize of everything you have discussed in the sequence. The 2.5 years X-rays still maintain the bone completely stable. And if the bone is there, if the bone peak is there, what happened with the tissue? The tissue is mature and the tissue is going to fill the space, going to fill the papilla. As you see almost in a 4 years follow-up picture, all the space that you let for the papilla completely fill the space between one implant to the another. So we left from a completely challenging case for a case that is much more strong and stable now. And here is the comparison of a regular way that people still manage the implant. And here is the protocol that we have established, especially to place one implant to each other, okay? In this case here that I received in my office, I had an implant, good platform, conical connection, but they had filled this implant with a lot of acrylic since the beginning. A lot of acrylic. What happened with the acrylic and the soft tissue? I create epithelial layer. Epithelial layer to the connective tissue, the space is much more wider. That's why in that case, I have all the bone running far away from this implant. Imagine you receive this implant here and you still need to place an implant in one of the interproximal teeth. It's going to be a very difficult case for you to manage. So if I had taken this case since the beginning, work biologically with a longer abutment, more biocompatible friendly, probably the bone is going to be much more wider sideways. And even if I have to do any manipulation in one of the interproximal bones, we're still going to have a good bone pick in the long term here. And this is another way, the same that we have shown in the beginning, even having two implants side by side, the interproximal bone is strong because of the different ways to think about the structures that you are building, okay? Guys, I'm going to let my contact here. If you scan, you're going to have the WhatsApp contact that you have from my team. So any information that you want to have about the lecture or about the places that you have running courses around the world, you are really here with the contact available for you guys in the sequence. And as well as Raquel, Zita, and all the guys that are here, we're going to be during the lecture. If you have any questions here during the days, please, we are welcome to talk to me during this day, okay? So thank you so much for being here and have an understanding our outstanding day of lecture today. Okay.
Beautiful lecture, Ricardo. Oh, congratulations.
Good picture. Good.
I'm going to take